Good morning, guys. Today we're continuing discussion about cardiovascular system. And today's topic is heart defects. All heart defects we divide to acyanotic and cyanotic heart defects. Acyanotic heart defects are congenital cardiac malformations that affect the atrial or ventricular walls, heart valves, or large blood vessels. Common causes include genetic defects, for example, trisomies, maternal infection, for example, rubella, or maternal consumption of drugs or alcohol during pregnancy. Acyanotic heart defects are characterized pathophysiologically by a left-right shunt, which causes pulmonary hypertension and right heart hypertrophy. So at the end of all these defects, all acyanotic defects, we have hypertrophy of right chambers. The symptoms depend on the extent of the malformation, resulting in high rate of cardiac function. Infants may be asymptomatic or present with exercise intolerance, failure to sleep, and symptoms of heart failure. Characteristic heart murmurs are important clues for establishing the diagnosis, which is typically confirmed by visually the defect on echocardiography. Heart murmurs you can hear if the size of the defect is very small. If defect size is large, you can't hear heart murmurs with stethoscope. A chest X-ray, MRI, or cardiac catheterization may also be required to determine the indicators for surgery and to plan for the procedure. Acyanotic heart defects require treatment and required via catheter procedures or surgery. Supportive medical therapy is needed in the causes of heart failure. For example, diuretics, inotropic agents, or if surgery cannot be performed, prostoplasty. Common complications include arrhythmias, embolisms, and infective endocarditis, especially if treatment is delayed. Common pathophysiology to all acyanotic heart defects. The left chambers of the heart are a high pressure pump system, and the right chambers of the heart are low pressure pump system. Heart defects may lead to the formation of connections between the two systems, shunts allowing blood to flow along the pressure gradient from high to low pressure. The shunts are classified according to the direction of blood flow as left to right shunts or right to left shunts. Left to right shunts. Oxygenated blood from the lungs is shunted back into pulmonary circulation via atrial septal defects, ventricular septal defects, or patent ductus arteriosus. At the end, it causes to pulmonary hypertension and right ventricular pressure overload. It causes to right-sided heart hypertrophy, and you can see cardiomegaly on X-ray clips. Including you have heart failure syndrome, but no cyanosis. Eisenmenger syndrome is also lying on the pathophysiology of many heart defects. And it explains that prolonged pulmonary hypertension due to left-right shunt causes reactive constriction with imminent remodeling of pulmonary vessels. Reversible pulmonary hypertension. Right ventricle hypertrophy to compensate for pulmonary hypertension goes to right ventricular pressure becomes higher and eventually exceeds left ventricular pressure. It caused to reversal of blood flow associated with onset of cyanosis either at rest or during exercise. Right to left shunt, blood flows from the right to the left heart via shunt, and deoxygenated blood enters systemic circulation. You can see clinical symptoms of cyanosis. Untreated left to right shunt has cyanotic heart defects may progress to right to left shunt. Cyanotic defects if right ventricular pressure exceeds left ventricular pressure due to pulmonary arterial hypertension. And this phenomenon has the name Eisenmenger reaction. And you should know about there are very many types of acyanotic heart defects congenital. Acyanotic heart defects, but you should know about uh, three of them. It is ventral septal defect, atrial septal defect, and pattern ductus arteriosus. Atrial septal defect. Epidemiology prevalence nearly 2 per 1,000 live births. Etiology may be Down syndrome, may be fetal alcohol syndrome, Holt-Oram syndrome, pathophysiology of this defect. Acquired growth or excess resorption of the atrial septum, in utero leads to atrial septal defects. It's morphologically, the defect has two types. First one is osteopneumomaterial septal defect, which is meeting 15-20% these babies with this heart defect. And second one is osteum secundum. 70% of babies with atrial septal defect has second type. Typically, low pressure, low volume, in or left to right shunt patients are asymptomatic. Large defects in shunts may lead to right heart failure, supraventricular arrhythmias, pulmonary hypertension, or pulmonary and of the is a major reaction. Cardiac hemodynamics in atrial septal defects, types of atrial septal defects. Clinical symptoms depend on the defect size and shunt volume. Small defects usually are symptomatic, large defects in large defects you can meet all symptoms of heart failure syndrome. Atrial septal defects typically manifest with advancing age. And you should remember about auscultation peculiarities. Auscultation peculiarities of this defect is systolic ejection movement over the left second intercostal space, sternal border. Second intercostal space, sternal border. This question is meeting at your module and examination institute. Auscultation peculiarities of atrial septal defect. Widely split second heart sound over the left sound, intercostal space, which is fixed, does not change with respiration. Normal sound 1. Soft means diastolic movement over the lower left sternal border. Diagnostics. Diagnostics is echocardiography, the major to visualize the defects. Chart 4. If the cardiogram, vertical or right axis, you can see deep pulmonary, right bundle branch block complete or incomplete signs of right heart hypertrophy, air confusion. My microphone is working. I don't understand why you can't hear me. Chest X-ray. Enlarged right atrium, ventricle, and pulmonary arch, increased pulmonary vasculature. Treatment in childhood spontaneous closure may occur. Parts repair indicate in symptomatic children with significant left-right shunt, surgical or VR percutaneous transcatheter procedure, and also these conditions has complications as paradoxal embolism. In this condition, increase the risk of stroke in babies. Next defect is ventricular septal defect. The most common congenital heart defect with 4 per 1,000 live births occurs as an isolated heart defect or in combination with others. Etiology: genetic syndromes, as Down syndrome, Edwards syndrome, Fatal syndrome, fetal alcohol syndrome, intrauterine infection, as torch infection. Localization, most commonly in the membranous part of the ventricular septum, pars membranacea, defects in ventricular septum left to right shunt with the following consequences: right ventricular volume overload, right ventricular hypertrophy, excessive pulmonary blood flow, increased pulmonary artery pressures, and it calls to pulmonary hypertension and right-sided right hypertrophy. Decreased cardiac output, possibly an Eisenmenger reaction in late stage or disease due to irreversible pulmonary hypertension. Cardiac hemodynamics ventricular septal defects depends on the size of this defect also. Clinical peculiarities, clinical findings. Small defects, usually asymptomatic, medium-sized or large defects, leads to cardiac failure in the first 2-3 months of life. Before this age, you can see the compensation process in the clinic. Some ventricular septal defects can present after the first week of life because pulmonary vascular resistance is higher at birth and decreased thereafter. Decreasing of pulmonary vascular resistance goes to decreasing of right ventricular pressure. It goes through increasing of left to right shunt, and we can see the presence of symptoms of cardiac failure. Palpation fitting, hyperdynamic precordial may be detected hemodynamically, relevant defects. Auscultator reflectance. Harsh, hollow systolic murmur over the left lower sternal border, typically louder and small defects. Becomes louder with maneuvers that increase left ventricular afterload. For example, a hand bleed because of increased left to right shunting. Also, during auscultation, you can hear mid-diastolic murmur over cardiac outputs. You can hear systolic thrill, and you can hear loud pulmonary sound too if pulmonary hypertension develops. Diagnostics. Also, Doppler echocardiography confirms diagnosis, evolution of the defect size and shunt volume, exclusion or other anomalies. Electrocardiogram, signs of right heart hypertrophy, chest X-ray. Enhanced pulmonary vascular markings, left atrial and ventricular enlargement, in later stages enlarged right ventricles and pulmonary artery due to elevated of PVR. Treatment: small VSDs, ventricular septal defects rarely require surgical interventions. Small to moderate defects often heal spontaneously. Follow-up echocardiography recommended. Symptomatic and large VSDs. Treatment we at the scientific as treatment of heart failure syndrome. Surgical bed repair children before 1 year of age with signs of pulmonary hypertension and older children who did not improve with medical therapy. Closure of ventricular septal defects results in decrease in right ventricular and left atrial pressures and an increase in left ventricular pressure when compared to pre-treatment values. Heart lung transplantant or lung transplant with concurrent with the repairs if Eisenmenger reaction has occurred. Its complications may be arrhythmias, right heart failure, Eisenmenger reaction, infective endocarditis, aortic regurgitation, subaortic ventricular septal defects. Next defect. Patent foramen. The persistence of the foramen beyond 1 year of age is uh, normalcy. 25 to 30% of the general population, the foramen ovale in the atrial septum does not close afterwards. And pathophysiologically, we can see built left to right shunt. The shunt reversal may be included by certain maneuvers that induce an increase in right atrial pressure. For example, Valsalva maneuver and Coping. Clinical findings. Patients are usually asymptomatic until complications occur. Diagnostics often an incidental finding. If ischemic stroke occurs, specific workup for suspected patent foramen ovale. If needed, contrast echocardiography, best initial and confirmatory test, shunt identification, assess structure and function of the heart. Applications may be paradoxal embolism, systemic embolism, renal infarction. Treatment asymptomatic are patent foramen ovale. The majority of causes do not require any treatment. Ischemic infarction in patients with confirmed patent foramen ovale, medical therapy with antiplatelet agents or anticoagulation and surgical or percutaneous closure of the defects. Pathophysiology failure of the ductus arteriosus to close afterwards results in a left to right shunt, volume overload of the pulmonary vessels. Resentment direction may occur with shunt reversal and present with differential diagnosis. Cardiac hemodynamics in patient ductus arteriosus. Clinical features. Small PDA asymptomatic with normal symptoms on physical examination. Large PDA, we can see non-specific symptoms, failing to sleep, and symptoms of heart failure in infancy. Physical examination. Having laterally displaced apical impulse, bounding peripheral pulses, wide pulse pressure, pulse stellar et altus, auscultatory findings, loud continuous movement, machinery movement, bed hurts in the left interventricular region. Diagnostics and cardiography confirmatory test shows left cardiac enlargement, large DPTs, Doppler, assessed degree of shunted pulmonary artery pressure. Color Doppler demonstrates blood flow from the aorta into the pulmonary artery. Electrocardiogram normal in small PTA, left axis deviation due to left ventricular height, large PTA. Chest X-ray prominent pulmonary artery and aortic knob along upper left heart's border increase pulmonary margins. Cardiac catheterization and angiography only necessary prior to repair or in more complex congenital heart defects. Treatment, observation, and regular evolution of the heart and pulmonary vasculate is indicated in patients with a small PTA without evidence of left-sided heart volume overload. Elective ductal closure, indications for closure, and systematic PTAs. Left heart enlargement or mild moderate pulmonary hypertension. Techniques, pharmacological closure, premature infants, infusion of indomethacin or ibuprofen. Pharmacological closure can be used to closure or to decrease. In infants, more than with body mass more than 5 e.g., percutaneous catheter occlusion or surgical revision. Administer prostaglandin if the PTA is needed for survival, for example, in transposition of the great vessels, heterology of palate, hypoplastic left heart. Its complications may be heart failure in infancy, infective endocarditis, common cause of pulmonary hypertension, and Eisenmenger syndrome in adolescents and adults. Next defect, coarctation of the aorta. Narrowing of the aorta in the aortic nose, prevalence of 4 per 10,000 live births. In boys, this defect is needed faster than in girls, usually associated with bicuspid aortic ventricular septal defects or PTA. Fractation of the aorta may associate with Turner syndrome, pathophysiology, genetic defects, and or intrauterine ischemia, medical ischemia, human hyperplasia from a reach, and circling the aortic fluid. Narrowing of the aorta goes through increasing flow proximal and decreasing flow distal to the membrane. And key working compensatory mechanisms, myocardial hypertrophy and collateral blood flow. For example, if postal vessels, scapular vessels develop causes of discrete stenosis to compensate for this left ventricular outflow, that subduction common. One set of symptoms usually later in childhood. In long segment stenosis, there is no time for developing of compensatory exposure of PTA, afterbirth, left ventricular pressure, and volume overload, hypoperfusion of organs and extremities distal to the stenosis, heart failure, cardiogenic shock. Coarctation of the aorta may be as hypoplastic type and hyperplastic type. Clinical findings in newborns asymptomatic PTA is present or aortic narrowing is only mild. Cyanosis in lower extremities, differential cyanosis, big femoral pulses, brachial femoral delay, enlarged stenosis, big and mid symptoms of heart failure, in severe stenosis, shock, and multi-organ failure when due to bacteriosis causes. On the chatbot, we can see symptoms as chest pain, cold feet, and lower extremity cloud notification on physical exertion. You can see an increase of pulse in the upper extremities and decrease in lower extremities. Auscultation frequency including systolic ejection murmur over left paravertebral region and or continuous murmur below left clavicular and between the shoulder blades. Palpation of strong displayed apical impulse to the left. In adults, it may be hypertension, variability in blood pressure in the upper and lower extremities, headache, epistaxis, tinnitus, cloudification of the lower extremities with exertion. Diagnostics best initial test upper and lower extremity blood pressure measurements and search for brachial femoral delay. Pulse oximetry decreasing of blood saturation, echocardiography with Doppler, confirmatory dislocation and extent of stenosis, concurrent anomalies. On X-ray, you can see cardiomegaly and increasing of pulmonary vascular markings. Treatment initial management infusion of prostaglandins. Surgery should be performed as soon as possible in critical causes, in surgical correction or valve angioplasty. Follow up and monitor for stenosis, aortic aneurysm, and aortic dissection. Complications may be a secondary hypertension or cerebral aneurysm in adulthood. Intracranial, it caused intracranial hemorrhage, heart failure, aortic dissection, coronary artery disease, endocarditis, ischemic stroke, myocardial infarction. And the last acyanotic defect is endocardial fascial defect. Defect of atrioventricular valves, mitral and tricuspid valves, as well as atrial septum and ventricular septum. Complete form ASD and VD, common atrioventricular valve. Partial form only ASD and minor atrioventricular valve abnormalities. Strongly associated with Down syndrome, maternal diabetes, and obesity. Complete form ASD and VD, atrial and ventricular left to right shunt, excessive pulmonary blood flow, and ventricular volume overload, pulmonary hypertension, and heart failure. Partial form only ASD, atrial left to right shunt. Symptoms may remain minimal until adulthood. In both form, abnormal atrioventricular valve, atrioventricular valve regurgitation in several causes, nuclear heart failure, non-immune hydrocephalus. Clinical features may be different. There is no specific symptom to heart failure symptoms. And diagnostics is constantly as are other defects. Echocardiography, electrocardiogram, chest X-ray. Treatment. Treatment. We should treat the symptoms of heart failure and surgical repair if defects very large. Is it a common clinical symptom? It's heart failure syndrome in all defects. About cyanotic heart defect, we'll discuss next lecture. Now let's discuss about heart failure syndrome, which is meeting at all congenital heart defects as clinical symptom, as complication. Heart failure in children differs from it in adults in many respects. The causes and clinical presentations may differ considerably among children of different age group between children and adults. The time of onset of heart failure holds the key of the etiological diagnosis. Clinical presentation of heart failure in younger children can be non-specific, requiring heightened degree of suspicion. The overall outcome is heart failure is better in children than in adults. Heart failure in children is commonly due to structural heart disease and reversible conditions which are limitable to therapy. The principles of management include treatment of the cause, correction of any precipitating event, and treatment of systemic or pulmonary conditions. So, heart failure in adults has been the subject of extensive research and generation of evidence-based guidelines that describe of evidence-based pediatric heart failure. It is defined as an abnormality of cardiac structural function leading to failure of the heart to deliver oxygen and raise capillary rate, the requirements of the metabolism tissues despite normal filling pressures, or only at the expense of increased filling pressures. The causes of heart failure in children are significantly different from those usually responsible for the condition in adults, which include coronary artery disease and hypertension. In children, cardiac failure is most often caused by congenital heart disease and cardiomyopathy. Congenital heart disease occurs in around 8 per 1,000 live births. Heart failure associated with congenital heart defects occurs in approximately 20% of all patients. Many of the children with congenital heart defects receive early surgical intervention, and it has been estimated that the yearly incidence of heart failure as a result of congenital defects is between 1 and per 1,000 live births. The outcome of heart failure related to congenital heart defects has changed dramatically following the introduction of early surgical interventions. The incidence of symptomatic heart failure has also decreased in the early surgical area. Cardiomyopathy also contributes significantly to the number of pediatric patients who present with the symptoms of cardiac failure. 27% of children with heart failure syndrome have abnormalities in the heart muscle as an underlying cause. Another minor group of disease causing heart failure in children is developing countries with rheumatic fever and rheumatic heart disease. While the incidence and prevalence of rheumatic fever and chronic rheumatic heart disease are well documented, there are scanty data of presentation with heart failure in this group. A significant number of acute rheumatic heart disease and established juvenile mental stenosis present with features of heart failure. Heart failure in children can be divided into two groups: overcirculation failure and pump failure. Overcirculation failure results in volume overload of cardiac chambers. The left ventricular function is either normal or left ventricular is hypercontractile. Pulmonary venous or arterial hypertension may be present to a variable degree. Causes of pump failure include both congenital and acquired conditions. Left ventricular or systemic ventricular function is abnormal, and most patients have pulmonary venous hypertension at growth. Causes of overcirculation heart failure may be conditions associated with increased pulmonary blood flow, left-right shunt like ventricular septal defect, patent ductus arteriosus, aortopulmonary window, and atrioventricular defect. Admixture lesions like total anomaly of pulmonary venous connection, single ventricle, parallel circulation as in transposition of great arteries, conditions causing increased cardiac output, anemia, systemic arteriovenous fistula, beriberi, regurgitant valvular lesions, mitral and aortic regurgitation, congenital, rheumatic, and infective difficulties. In the causes of heart failure, maybe congenital causes, obstructive lesions like left ventricular outflow, depth, obstructive lesions, aortic stenosis, coarctation of aorta, right ventricular outflow, obstruction, and pulmonary stenosis. Anomalous region of left coronary artery from pulmonary artery. Post-operative congenital heart disease with ventricular dysfunction. Pump failure may be due to inflammatory processes, due to vital myocarditis, hip-related and Chagas disease, related cardiomyopathy, idiopathic familial neuromuscular disease, and schizophrenia. Rhythm disturbances, acute cardiomyopathy, and complete heart flow. It's about clinical examination of patients with cardiac failure, heart failure, and also cyanotic heart defect. Let's continue in next lecture. Okay? Guys, class is off. You are free.